Well, Lyndsey, thank you so much for joining me on the You're Not Alone podcast today. I'm really excited for today's episode. And I know we were texting back and forth before the episode, but you actually made my life really, really easy today. And you were like, I hope I didn't step on your toes. I'm like, no, I think that this needs to happen more often. You sent me really a really detailed list of questions to cover today in your field of expertise. And I'm really, really excited to dive into talking about substance use and mental health treatment facilities. I think it's a really, it's an important conversation and one that isn't discussed enough in the public sphere. So I want to stop talking for a second and give you the opportunity for a quick introduction.
Well, thank you. I think that kind of tees it up pretty well because that's my anxiety that does those things and sends you this list of questions because I like to be fully prepared for things. And I was thinking about it because my formal diagnosis, so I have a generalized anxiety disorder, which has been a lifelong learning process for me. Started when I was a kiddo, and I had to chuckle because I saw a meme or, whatever they're called on social media about one of my friends shared that said, if you were the kid in elementary school that counted how many people were before you so you could practice, where your anxiety started. And it took me way back to that time period. And I was like, wow, yeah, I actually did that. And I would rehearse and I'd blush, I'd get beet red, and I would be so nervous that you could just tell. So, I've been living with that for, I won't say how many years.
We're going to keep that a secret, huh?
That's between us on this one. Not many of that. It wasn't too long ago.
Yeah.
So, I worry about different things, and I say my superpower for overcoming my anxiety is that let me be as prepared as possible and feel a little bit more confident because at least I've done some attempt at mitigating risk by doing so. So that's a little bit about me.
Yeah, I relate to that too. My formal diagnosis is OCD, or obsessive compulsive disorder, which really came to the forefront in 2016 for me, and having many, many conversations with my mom, who she's an angel and a saint. I think I can track back my anxiety back to childhood too. I was a very anxious little boy. I mean, I think one of the big things for me is I never wanted to upset other people or make other people feel bad or let other people down. I was petrified of failure, which really did not bode well in the sports arena where, while other little boys are running around playing the game, I'm thinking in my head about who likes me on the court, did I make a mistake, blah, blah, blah. And I think it wasn't until I got older and realized, oh, this is all anxiety, that things started to change for me. But so I relate to that. I relate to the anxiety and trying to mitigate some of that risk. I mean, sometimes it feels a little futile because the anxiety is still there, but we still try. What got you into this line of work as a licensed clinical social worker and then doing the work that you do now?
So it's been an interesting journey. It actually started out, I just always loved helping people. That was kind of my thing. And I loved watching and trying to figure out how people work. And it kind of helped me feel better with my anxiety too, because I was always worried if I was being judged, right? So if I could read another person and understand kind of what made them work, or maybe what they were thinking a little bit, or how they were responding, like, oh, they like that I said that, I got a smile and a nod, then it started to make my life easier. And so I spent a lot of time in school kind of doing those things. And actually, true story, my first career choice was going to be straight out of Criminal Minds. I was going to be a forensic profiler, was real into it. So I started studying primarily deviant psychology and kind of along that path. And I loved every single thing about it. And I was finishing up my undergrad in psychology at Kent State, because I'm from Ohio. And I met this really cool teacher who was like, hey, social work is where it's at. Like, you love all of these different areas. Like, this way you can study the whole person and you can actually really study them in their environment.
Yeah.
And I was like, whoa, really? They'll let you like actually take into account, the other things impacting how someone's experiencing the world around them. And she was like, yeah, you're going to love it. And I was hooked from that day on.
One.
And
yeah,
that did it.
That's really cool. And so, so it sounds like you started out in social work. How did that dovetail into substance use and mental health treatment facilities? How did that become a specialty for you?
So I feel like I have too many stories, but in all honesty,
stories are a great thing. Love stories.
When I started graduate school, I was actually working full-time with the Department of Children's Services. And I was at a location in Ohio, and it was the very beginning, which this might give away my age, but oh well. I was at the very beginning of the overprescription of opioid medication.
Oh no.
And we were really kind of seeing the impact that had on families. And there was this viral video, right? I mean, the internet was exploding and social media was just starting, of two individuals that were lost consciousness, had overdosed in their vehicle. And there was a kiddo in the back seat. And I remember, my Department of Children's Services brain was like, okay, he's buckled, he's dressed appropriate for the weather, the windows are down. Okay, they love him and we're trying to do what they could. And then my mind flipped to, oh my gosh, these poor people are so ill, right? Like, addiction is a true brain disease. They're so ill at this point that they love their child enough to take these precautionary steps, but they're so driven by this innate drive for substances to avoid being sick, to avoid pain and suffering, that I couldn't understand it.
Yeah.
And it was this kind of struggle, this internal struggle in my mind that was like, how does this happen? How can a need for the avoidance of pain and using substances take away from the innate drive to take care of a child, right? I mean, these are kind of fundamental things that we think about. And I just said, I have to add this. I have to learn. I need to understand this. And at the time, the university at Youngstown State University, they offered a dual track. So you could study social work and then add the addiction is what it was formerly called then before it transitioned. But you could take a track and learn group work and understand the disease model, because it had come out and it just fascinated me.
What is the disease model, out of curiosity?
So they had transitioned it, there's so many different schools of thought, but originally they looked at addiction and substance use disorder as moral failing.
Wow. Okay.
Yeah, this was old school train of thought.
Yeah, that is old school, because I feel like anybody who's close to substance abuse now knows that there are some really, really, really great people out there that they can't sit and have one drink, that leads to a month down the road. I had a guy on the podcast about a month ago. He's an awesome guy. He owns a gym out here in Orange County. And he was the kind of guy that it might start out as one beer at the bar with some friends, and a month later it's like waking up blacked out on a couch, crack in his pocket. Like he can't, there's no like shutting that off. Like once it starts, it's all the way.
And you articulated that so well, because that's the disease model, exactly how you said it.
Okay, there we go.
Yeah, look,
yeah.
You see, you know more than you even do.
There we go.
Because that's really what it looks at, is people are like, this isn't a moral failing. You can't will yourself to stop this behavior, or these people would. And, they were doing some strange attempts at treatment.
Yeah.
In state hospitals, because they were learning, and that's just how things were. But it finally evolved into the American Society for Addiction Medicine recognizing substance use disorder as a true brain disease, that when you introduce substances, the chemicals and illicit substances or legal substances into your brain, that it actually alters the chemistry. And they did the research on I'm going to nerd out for a minute, but on the
Yes.
neural pathways that
Yeah.
form.
Yeah.
And it actually transitions, it will reshape your brain. Like there are some incredible like brain scan images that you can look at, and it will show you what an active addiction looks like in the brain, and the what's lit up and the areas that are stimulated. It's mind blowing, and they're very similar. I mean, it takes the same trajectory that it does for breathing. It becomes an automatic need and response, and that drive becomes very powerful.
Wow. Wow. Do you know specifically, or do they know specifically what regions get lit up? I don't want to put too much pressure on that, but do they know what regions get lit up?
A lot of it has to do with which chemicals you're putting into your system. So like your dopamine receptors, frontal lobe, like different things.
Okay. Okay. Yeah, that makes sense to me. I know that there's definitely like a dopamine component. That's interesting on the neural pathways, that they start to follow the same, like, I guess, it's the same pathways that have to do with breathing and aspects of, wow, that's really interesting. I think that's important for people to know too, because it is all neuroscience at the end of the day. Okay. And so that's sort of what propelled you into this path, was to understand why, what drives people despite being even so loving. You can clearly tell that they love their children, but they just can't stop using. And that's what drove you to this sort of career path. So have you worked at a substance use and mental health treatment facility?
I've been in a couple.
Okay.
I've tried some different paths, and I've been so fortunate in my career to be given a lot of different experiences to really look at clinical programming. And I've been in for-profit, not-for-profit. I've been in community practices, hospital settings. So again, I've been very fortunate. I believe things happen for a reason, and the trajectory of my professional career has really reinforced that for me. I wouldn't have been where I am today if I hadn't had all the experiences that led me here. So it's been a lot of learning, and that's what transitioned my focus to specifically stay with co-occurring disorders. I don't, it's very rare. It does happen. It is very rare that someone lives their life with only one mental health disorder, right? We all experience trauma. We all experience anxiety. We all have bouts of grief. So, I mean, there's all of these interplays of what's going on inside of us that we have to look at. And that was the beauty of social work, right? We can look at someone's physical condition and how that contributes to how their brain's functioning, right? Diabetes, for example, is a life-altering diagnosis that has a behavioral component and is strongly correlated with depression. I mean, it's very rare that people don't experience at least a single episode of depression after a life-changing diagnosis.
Yeah, totally. And I think talking about trauma is a whole other conversation in and of itself, because it impacts everybody in society, and it's sort of like this big secret that isn't being talked about at scale, because everybody could be treated for trauma, and trauma's relative, which you and I we talked about this. You shared it in your notes. Like, everybody's trauma looks different. And I think that a lot, like even going through a breakup, like a really significant breakup, can be traumatic, but I don't think like the common person walking around would look at it that way. So it's sort of interesting that you bring that up. So let me ask you this, because I think when I was thinking about the layout of this episode, you laid it out literally perfectly in your notes. It's going to be the person who's, I think, trying to figure out whether a treatment facility is right for them and navigating that path. So can we talk a little bit about sort of that step-by-step process, beginning with the whole to Google or not to Google, this is the question idea? Where does somebody get started when they're trying to figure out if a mental health treatment facility is right for them?
I think honestly and this is a challenge, because most people that are at this state are overwhelmed by what's happening inside of their minds and what's going on around them. And it becomes hard to think to yourself, what are my goals? What do I want out of treatment? What do I need? And sometimes I need relief from what's happening right now. And it's so severe that if I don't do something, something really bad's going to happen. I mean, when we start talking about the exploration of treatment facilities, that's your, aside from a hospitalization, I mean, that's your highest level of care that you can receive.
Mm.
So, I joke I think everything's worth a Google, and I say that loosely because we will self-diagnose. You'll Google and come out with 15 personality disorders and
Yes.
all
Yes.
kinds of other things.
Totally.
So I say it's a cautionary tale. You can't believe
Yes.
everything you read.
Totally.
Because we all have traits of, personality disorders aren't inherently good or bad per se. We exhibit traits of all of these. So I always caution on that one. But I think, taking a little bit of an effort to understand what you're able to do and what makes the most sense for you, because a commitment to a treatment facility is around like 30, 60, 90 days. It kind of just depends.
Okay.
And that's kind of where that Google starts, right? You've defined these goals. I need relief from my severe anxiety and depression. I'm having some suicidal thoughts. I don't feel safe anywhere. And that's on the mental health route. If it's substance use, I'll try to talk in both. I can't stop myself. I don't have a healthy recovery environment. I need to get out of this to be able to even start to have my brain reset, right? To go through that detox process. So that's what I always kind of say. So when you start Googling treatment facilities, you have to have an idea of what you're looking for.
Yeah. So you need to define what you need in that moment. If somebody is at their lowest point, do you recommend that they go the hospital route right away to start? Like if they're, really close to attempting, is that sort of the route that you would recommend? Or, I mean, I guess what would somebody at their lowest point do? And then what's somebody who feels like they still have a little bit of control? Like what should they do?
I'd say, what our hospitals are designed to do is really assist someone who's an imminent risk to themselves or others.
Okay.
And I have this conversation so many times, and it's so hard with parents who are watching their loved one and they're injecting heroin. I'm so concerned that they're going to have fentanyl and they're going to overdose and die. And I don't know what to do. I'm going to take them to the hospital. And then I'll get a phone call and they won't take them. They won't treat them. They say they're not at imminent risk. And that's when there's the opportunity, if you have a loved one and a support person, because if you're that ill, it might not be the first thing you think of. Usually someone helps come on that journey with you.
Yeah. That's
when you start Googling a residential or a detox facility.
Okay. That's a helpful distinction. Because the thing that's complicated in advocacy work, and you probably see this too, is like, I feel like there's a lot that our hospitals need to do to catch up with care and support when somebody's in that fragile space. Because there was this was a little bit back now, but there was this young girl who took her life. I think it was in Canada, because she was considered not a harm to herself after going to the hospital, and they released her. And I mean, the very first thing she did when she left was she, death by suicide. So she took her life. So it was, that's interesting, but I think it's important to talk about, to sort of get that awareness out there that sometimes the hospital, do you think that the hospital in some cases is like a last resort? Is that tough to answer?
That's a tough one. I think that the short answer is yes. I do think that the hospital's last resort, because then what ends up happening, if a traditional hospital setting, is if you present to an emergency room department and, it's just a strange way to describe it, but I've worked in emergency departments before. And the treating physician has 2 critical patients coming in from a vehicle accident versus someone who's sitting there who's saying, I feel like I want to die. They're going to treat critical patients first. And that can transition into that individual who is suffering and who needs help and who needs support right then, 3 to 4 hour long waits. And if that hospital that you go to does not have a linkage to a psychiatric facility, because there's a key distinction right there, then they'll refer you somewhere else.
So what is that key distinction for people listening? I think that's important.
I would say, I always, if you need to go, if there's something, get emergency treatment, I'm not saying that that's not the course to go.
Yeah.
However, what I am saying is if Indiana, because that's where I'm at right now, I know a community hospital system has a psychiatric unit and a psychiatric floor.
Okay.
So if I refer someone for psychiatric inpatient care, Eskenazi, there's other facilities. I don't want to just single them out. That's just what popped in my head first. I'll say, please present to their crisis center.
Yeah.
And that's the distinction. Don't go to the ER, please go to their crisis center. And, that's me as a human, me as a treatment provider, will call ahead and say, I'm sending someone, this is what they disclosed. I'll send you my documentation, because the other challenging piece is if that person realizes that they may be going into a locked facility, there's that moment of, oh no, right? Like, I don't want to be locked in a hospital. And that anxiety, that freak out moment happens.
Yeah.
And they show up and they say, no, I was just kidding. I didn't mean any of that. And the provider there is then left with, they said that they did this for X, Y, and Z. I don't have grounds for psychiatric admission. And that's what becomes really, really hard. And that's why if you're a loving support to someone like that and you show up and you offer collaborative information, then that can really be helpful.
Okay. Yeah. So a loved one coming along with the individual to talk to the healthcare provider about what's going on. That makes sense to me. I think that that's a really helpful bit of information there. You have a lot of different options written down: residential treatment, like a superintendent's 30-day, a PHP, an IOP, OP counseling, co-occurring. Can you walk the listeners through that?
Because there's a million different options and they look different everywhere.
Yeah.
It's alphabet soup, I guess. It can be really confusing and overwhelming, and that's why I'm grateful for the opportunity to talk about it. So when you're looking at intensive treatment, you're looking at residential. They have, and that's primarily co-occurring and substance use disorder. I have to disclose that because most areas, that's the designation, right? You're going to look for one or the other when you define those goals of what you need.
Okay.
Partial hospitalization programs, and a lot of this is driven by funding sources, which is a hard thing for us to acknowledge, right? Because treatment should be accessible by all, right? But unfortunately, healthcare is what it is, and there's different factors that come into that. So partial hospitalization programs are kind of your next step.
Okay.
And those are for people that have a supportive living environment where they can maintain safely, right? I'm not an imminent risk. I may have thoughts of my life's overwhelming, I want to die, but I don't have a plan and to die by suicide. I don't have access to the means that I'm thinking of using. I can stay there and have some support and function. Like I can eat and take care of myself enough that I'm going to stay alive.
Mm-hmm. Okay.
And right, that's the distinction, right? You have to be safe to be alive. And, and then partial hospitalization, that's one of those options. It's they're really intensive. It's about 20 hours a week. You go usually check in at 8 a.m. You stay all day. You do treatment it's 20 hours a week. So that's about 5. Sometimes it's 6 hours a day. It just depends on location. You have a lunch break and then you go home. Okay. So it's a nice option for individuals that have children that can be safely taken care of at home with support, that may still be at a level of functioning where they can work a couple hours when they need to keep the lights on, right? So that's one opportunity, and that's a little bit more stable, right? You're in a different place.
Okay. And is that private insurance based as well?
Typically. It's going to vary by state. So I will say that. Okay. And probably the best thing I think anyone can do is look into their benefits. Insurance companies, they'll give you lists. That's a great starting point, right? This is what's covered, and you'll see all these fun letters. So if you don't start looking them up, it's overwhelming.
Yeah, and PHP stands for partial hospitalization program.
Yes, that's correct.
Okay, that's good to know. And it's also helpful that people should get a contact list or a resource list from their insurance provider so they can begin making calls. So what's IOP stand for?
So that's another fun one. That's your intensive outpatient program.
Okay.
And I'll say this too. So they have partial that'll say co-occurring, which is usually mental health and substance use. That will say primarily substance use or primarily mental health.
Okay.
So that's another caveat when you define those goals. You've got to, okay, I need one of these.
Yes. And I think that's important to talk about the goals, because the goals that you're defining are, what do I need to be treated?
Mm-hmm.
Is it depression? Is it anxiety? Is it intrusive thoughts? Is it thoughts of suicide? Is it substance abuse? What substances am I abusing? Mm-hmm. Is there something trauma related involved in this? So I think taking the opportunity to write everything down on paper, to get, even if it's just 5 minutes of like, this is everything, that's going to really help guide the decision.
Mm-hmm. Absolutely. And I'll say this, and this sounds kind of strange because people always raise an eyebrow when I say this, but yeah, I'm a huge proponent with preventative work. I think that if you know things about yourself and you take time to recognize, like, man, when I get overwhelmed, like my anxiety skyrockets and I get these intrusive thoughts, right? Then you know that about yourself and you're like, okay, I'm ball of anxiety. Or, you know, man, I get in these fits of depression. And there's a lot of people, I want to normalize this for your listeners too, that live every day and hit really hard spots, and they have thoughts of dying, of not waking up. If I could just go to sleep and not wake up, it would be easier. That requires treatment. You don't have to rush to the hospital for that per se, but you need to start talking about it. And the more we talk about it, the better we do.
Totally agree with that. Yeah. And I think that that's a very real reality for a lot of, there's a lot of people in this country and worldwide that experience that. So I think that's a really important point to talk about.
And it allows you to know if it's different this time. Do you know what I'm saying? Like if I normally, if I'm real dark and I'll be like, man, if I could just go to sleep and not wake up, it would be easier, versus I want to die and I want to do it. And I'm trying to watch my trigger warnings, the stuff that I'm saying a little bit, but if I'm going to do this and I want to do it on this day, that's a big difference. And that's when that evolves into something more, and that's more almost tangible. I guess that's the only verbiage I can think of.
It's a plan.
No.
Here's when I'm going to do it. Here's how I'm going to do it. Here's the letter I'm going to write to somebody to let them know that I care. Here are the possessions I'm going to start giving away. Like there's a whole, it's just much more concrete versus sort of having that thought and then going to sleep and waking up the next day and starting anew, So I think, that's a really good point. Really good point.
Yeah. So when that evolves, I mean, if you know yourself and you see that evolution, you're like, uh-oh, I got to get something right now. I got to talk to someone because this is really different. This is a different vibe. I've got a different feeling. I'm getting a little bit scared, and that level of persistence with it, right? Like it used to be a fleeting thought, like when I was having a crying episode or really upset, and now it's been like 3 hours and I can't get this out of my mind. It's there. Yeah. It's more intensive. So that's why I say, if you can know yourself and know the things that kind of happen when you're overwhelmed, then it gives you at least an idea of what's going on. And then when things happen, it's like, okay, it's almost like, you have a survival pack. Like, I know I get like this. Okay, something's different. I got to get a different help. I know it's my anxiety this time. And we teach people that in treatment, right? Know your triggers, know your warning signs, and know when trying to manage it yourself isn't working, know when to reach out. Okay.
So that's important too, for people to know that you start to gain those skills through the treatment process too, which I think awareness around triggers and what's going to intensify, anxiety or depression or bring on thoughts of suicide is really important, because for me in my journey, that's been a big the building that awareness has been a huge piece. So to the longevity of the recovery process. So what do you say about profit versus not for profit?
That's always a different space, and that's kind of where all these things come in, right? So when you're starting to look at what kind of treatment setting you're looking at, we get into there's this for-profit model, there's this not-for-profit model, and really that just designates who's paying for treatment, and what's available. So when we start talking about residential treatment, that's probably the biggest distinction that you'll see, aside from what levels of care you can access, because I say this, so for-profit treatment facilities, they're beautiful, they have great programming, they have more funding to put into some of the services that they're providing, and it's usually some of those ancillary services. That just means the menu's different. The extra activities that you can engage in are different. And, I've talked with a lot of families that are seeking treatment that I'll sell my car and I can afford this $30,000 a month treatment program and look at all the incredible things that it has to offer. They're going to get daily, and they're great. I think they're incredible. However, I always tell people you want to pick a treatment facility that is realistic to how you're going to live your life when you leave.
Okay.
Because I can go to a spa, I promise, and I will feel really great for at least 2 days.
Yeah.
I can't afford to go to a spa every day. I can't afford that to be my outlet if I'm overwhelmed and upset. I can't go get a massage today or go do acupuncture or go do something else. That doesn't fit my regular lifestyle.
Yeah.
And sometimes those things can overshadow what you're able to do when you leave, and you lose all of that. Like if you're like, oh man, yoga every single morning was the best thing for me, and you go home and you can't do yoga every day, you've lost that coping mechanism that you've built up.
Yeah, totally.
So that's kind of my guidance there. And there's some that'll have a private chef or will have this great nutritional coaching or these other things, which is fabulous. We need to learn how to eat in recovery for sure from a lot of disorders. But if you can't access that or don't have that at home, then it's almost a disappointment, and you almost forget that you can do other things. So I say just mirror it to what's more realistic, where mental health and substance use affect every demographic. So that's something to be cognizant of when you're making choices. Pick something that's like, you can go, and same thing when we pick location. Sometimes you have to get out of your area, but if you're going to go, there are some incredible facilities out where you are, like on the West Coast, that have mountain adventures and horseback riding and equine therapy, which I'm a huge proponent of. But if I live in a rural or a more urban area and have no access, can't find a horse to ride for miles, and that's become something that's a value to me, it's not going to work. So that's my cautionary tale about when you look at those different services that are added at it's certain levels of facilities, because that's very different. Yeah.
So it's looking for something that you can translate back into the real world once you're out of that treatment facility. And how long does treatment normally take on average? Is it 30 days, 60? I know you said 30, 60, 90. I mean, how long can people stay at a facility for?
That's a dependable variable on, what can you afford if you're in a for-profit cash pay. Most of them are what's clinically indicated. That's how they should operate. But there's some things that are different there. Relapse is a part of recovery in most instances. Almost all, I would say almost, because I'm sure there's that 1% that could prove me wrong. But, even mental health, we relapse again. We get into a dark place or have a bigger challenge and have to work through it again. So it just depends on what you need and what's available, because there's some that will say we're a 45-day program, and then you transition to a lower level, like a partial. Then you do our partial for 20 days, and they'll have a nice stepwise continuum. That's a key thing to look for, is making sure you have a continuity in your flow of treatment and you're stepping down to least restrictive. If you go from a 24-hour monitored facility to home with no services, your prognosis is not good.
Yeah.
It's a big shift really
Okay.
quickly.
So I think that that's important then to highlight too. So the recommended process is sort of like a step ladder down from 24/7 on-site services, everything, to back to everyday normal living. There needs to be that continuum, and you want to look for treatment facilities that offer that. Is that sort of the idea?
That's one thing that if they're available and you have access to them, a good amount will offer that. So they'll say when you complete in one of the questions. So when you said like, how do we pick somewhere? After you Google it and you say, this fits my goal. I like what you have to offer. This is something that works for me. There's, equine therapy, down the road at one of the farms where I live in rural Indiana. So that would be great. So I could do that and come back and do this. And I love horses already. I don't know why I'm picking that one, but that's where my mind went.
That's okay. I like it. I'm rolling with it.
So you want to make sure that that's available. So you call that treatment facility and you say, can you tell me what care looks like there? Okay, well, what's my aftercare plan? That's a good buzzword.
What's my aftercare plan? Okay.
What would my aftercare plan be when I discharge?
Okay.
It's like, oh, well, we recommend that you come to an intensive outpatient IOP program for at least 2 weeks. That's a good facility because they're thinking about your care. Yep.
Okay.
Or if they say, we'll do a referral to a different facility, you want to know, am I going to do I meet that person? That's very, is there a warm handoff? That's another buzzword you can ask about. How do I get there? You have to really think about those things. And I think that if you're, depending on what level of functioning you're at, is going to determine what questions you're able to ask. And if you're in early recovery and it's your first time and you're overwhelmed thinking about it, pick a facility that offers you a continuum out the door. You can still see familiar faces. You know what I mean? You have that linkage and that support built in.
Okay. I think that that's a really good call out. And talking about, and what was the question again in terms of when you're discharging? What's my aftercare? What's the aftercare strategy or plan here? Okay. What's that?
That should start at day one. They should know that before you even go in. We do this. This is, unless you have different needs, this is what it would look like. So
what are the questions that somebody should ask when they're calling into a treatment facility to decide whether or not they want to move forward with them? What are some of the, what are, I guess, some of the core questions? Obviously you have, what is your aftercare plan when I discharge from the facility? But even when they're trying to figure out what the inpatient looks like, what are those questions?
Yes, I think if you go through, you've got your, I say circle the wagon. It's a funny thing that we say. I think it's a Midwest thing, but you've got your goals, you've investigated and Googled, which one cautionary thing on that I forgot to mention is once you start searching, you're going to get inundated with little pop-ups that say, what are your treatment needs? And it can be overwhelming. So just close them out and Google on your own, because that does happen.
That's good to know.
Because it happens to me just when I look up. I did it before we hopped on and I was like, whoa, I don't need your pop-ups right now. I just want to look.
Yep.
For my own sanity. But, so you've got your goals, you've picked an option, you really kind of like what they have to offer. It fits what you think you want. You can call and you can say, can I talk to someone about what your facility looks like? And I say, you got to start with, what are your providers like? What kind of providers do you have? And if you're picking somewhere for mental health, you want somewhere that has a psychiatrist.
Okay.
On staff or contract, and you want someone, if it's an addiction facility, if they have an addictionologist, someone who really is in there, that's like, oh, okay, that's a good sign. Or, we work with this facility. You want to make sure that your treatment providers are fully licensed, or at least that there's one fully licensed individual on staff. That means they're a LCSW. I'll throw out a bunch of initials again, right? Here we go.
Yeah.
They're an LCSW, an LMHC, an LCAC. Well, there's a lot, but they're not master's level without full licensure, because when you're a fully licensed clinician, you have to uphold certain standards to maintain that license. You have to get continuing education courses. Same with medical providers. You want an MD. because these are the requirements. They have to stay up with best practices. And if they're not, then they get in trouble. So it's like this, there's always people that don't do what they're supposed to, but I mean, at least it offers some reassurance that you know that they're actively engaged and that they're keeping their license maintained.
Okay.
And that they follow ethical standards in those areas. So I like to ask, what treatment do you offer? Is it evidence-based? If you know nothing else, just ask, is this an evidence-based treatment?
Okay.
Because they'll tell you if it is.
Yeah. Do they have to legally tell you if it's evidence-based or not? Is that clarified?
You'll see it. Like it'll pop up. Like I did it just to refresh my brain before we hopped on. And it's like, we provide evidence-based treatment. We're certified in dialectical behavior therapy. So you'll see those things.
Okay.
That say.
Okay.
And if not, when you ask them, SAMHSA has an entire list of what's evidence-based. So this is tried, tested, and true.
Okay. That's a great resource too. So SAMHSA provides what all of the evidence-based treatment options out there. Is that talk therapy and medications that SAMHSA covers? Do you know? Okay.
Yes.
Okay.
Actually, and that's a really good point. Thank you for that, because when you're doing your guides, medication is something that's a really personal choice.
Mm-hmm.
Medically assisted treatment for opioid use disorder is a number one evidence-based practice intervention. However, some people don't want to do that. Yeah. And that's okay. But know that when you're choosing a facility, there's also facilities that in some trains of thought that don't permit people that are receiving substance use treatment to take psychotropic medication. So they're not going to prescribe you with certain medications that may be beneficial. But if you're someone who doesn't want that, then you need to think about that. And that's a great question to ask. What are my medication options?
Mm-hmm. Okay, so I'm hearing, what are the evidence-based treatment options? Who's the licensed professional on staff? What are my medication options? Any other questions?
Tons.
Yeah, I'm sure that's a loaded question in and of itself. Those are three ones that people can remember when they're evaluating. So I think that's important.
I think probably the last one that I want to make sure is you can ask, and they should provide you, what is your daily schedule? What am I doing?
Yeah.
And you should be able to see very clearly. You can tell I've designed a program or two, right?
Yes.
You should be able to clearly see, I have a wake up time. Your day should be structured basically from the time you get up to the time you go to bed.
Okay.
Even your free periods are still built in. Here's your free window for for journaling, meditation, completing assignments, or something. Recreation is scheduled. That's how you know they're running a tight program, because it's all in there.
Awesome. Okay. You want to see a complete wake up to bedtime scheduled program. That's how you know they're running a solid program. So what can people expect when they do go?
So when you do go, depending on what you pick, you should expect almost all facilities will give you a urine drug screen upon admission, because that's important. You're not going to get arrested. I have this conversation a lot.
Yeah.
You're not going to get arrested. If you're entering a substance use treatment facility, almost the expectation is that you're going to have a UDS that shows positive for a substance that you're using, because that's how we start treatment. We need a baseline, is what we say.
Okay.
So you're not getting arrested. You're not going to jail. We need to understand that. And even sometimes when you're entering a mental health facility, which happens, and there's no judgment here, this is just honesty, people don't disclose, I'm coming in, I'm need treatment for my depression. I don't want to tell you that I live in a state that marijuana is not legal. I don't want to disclose that I smoke marijuana every day.
Yeah.
So if they give you a UDS, it lets them know, okay, there's indications here. We got to talk about this.
Yeah. But it's not going to get them in trouble with the law. I
No.
think that's a very important distinction to make, because I could see a lot of people. And on that note too, how does this, because this might be a deterrent, how is this information articulated to, like, let's say it's a teen or a young adult? Does this information get disclosed to their high school or university? Does this information make it to an employer? I mean, how does it show up on a file or a record?
So the federal government has done a very diligent job of securing our records. It's called 42 CFR. It's worth a Google, right?
Okay.
That's
42
what
CR.
protects, 42 CFR. That's what protects the release of our records.
Okay.
And what that means is you have to read it. I'll give you the brief synopsis, but it gets disclosed to your payer if you're using a payer. So your insurance knows what you're being treated for. And there's limitations, but they have to know what like your diagnosis code, right? They're paying for it. They want to make sure that it's clinically indicated and that you're getting the services that you need.
Yep.
If you are referred by court, and you are court ordered into treatment, they will have access to your records. I've worked with a lot of departments. They're court ordering you for treatment in lieu of sentencing. Again, they expect a positive drug screen, or they did one at probation before you went, and now they know. Okay. So there's some things there. Those are the two big ones. The only other time it gets broken is if you are in a crisis situation. Mm-hmm. If, for example, you come in, I go see my primary care doctor and tell him that I'm actively suicidal. I have a plan. I have the means at home. I'm going to do it tonight. He can call and have me sent to a hospital and admitted. And he can break that. I don't have to sign anything because it's an emergency situation.
Okay.
Other than that, no one gets access to your records unless you sign what's called a release of information. And I tell people all the time, please read it. Don't check every box that you see. You don't have to. And if your provider is checking every box that's on there, ask questions. Okay.
That's good to know. On that release form, or is that part of when they're checking boxes, the release portion of it is on the form that they're filling out?
It'll be on the form that they're filling out. It'll say, they'll say, do I have permission to share your information with your primary care doctor for when you leave? So they know what you're treating. Look at the boxes with them, because there's like progress notes. My doctor doesn't need my personal progress notes. It's very rare.
Okay.
They don't necessarily need access to every drug screen that you did.
Okay.
You know what I mean? You can say, no. Like, please don't. I'm not comfortable with that. And that's your right. You need to advocate for yourself, because unfortunately people that do forms sometimes, and they get in a habit and they're like, we're just going to give them everything. Well, they don't need everything. You gotta be happy about that.
That's a little pro tip right there that you just provided. Okay, nice. So in addition to that information, what else can people expect once they actually show up on site?
You should expect a substance use treatment facility, and actually any treatment facility, you should, when you get your daily schedule, they should send you before you go what to bring.
Okay.
Like, what should I pack? And usually it's like 2 weeks worth of clothes max. You get a small space. You need gym clothes. If they have water stuff, you need water clothes, depending where you are, right? And you need different sizes, because people get really upset. And I see this often. If you are going into treatment, expect weight gain. That happens all the time. That's a healthy change typically. It's not a bad thing, but if you're only taking your girl and say you're only taking smalls, you're probably going to go up to at least a medium. Take something comfortable that you can have some room in, because that can cause challenges, and then you have to buy things and et cetera. But expect them to search your stuff. They have to check for contraband to make sure that you're only bringing in what you're allowed. Another pro tip on questions, ask if you're allowed. If you're a tobacco user, you need to ask if that's permitted, because in some instances it is not.
Okay.
Similar to states that have legal marijuana use, it may be legal in the state. It doesn't mean it's permitted within the facility.
What about things like coffee or tea? Are those available in these facilities, or is that considered a substance as well? Typically,
and that's a great question, actually, because it's one of the things that I always think about when I go in. because typically caffeine, depending on the type of facility that you're in, isn't always limited.
Okay.
You know what I mean? Like you can have, and that's kind of the other thing. They'll have soda pop machines and coffee all the time. And that's something just to think about. And there is a direct correlation between increased consumption of like energy drinks and transitioning in substance use treatment. It becomes a transition for people. And you'll see drinking 6 or 7 bangs. Yeah, bang. Remember those
Oh my
things?
God, those energy drinks. Those are like 5 to 6 of those a day.
Yep, you'll see it. And it's a treatment space.
Whoa.
Yeah.
That could put somebody into like cardiac arrest. That could like explode the heart, I feel like. That's a lot of. Yeah, that's good to know. That is. But I mean, and of course, Kate and I, my wife, we have friends that are, they're recovering alcoholics. They're recovering from substance abuse. And it's always feels like it's cigarettes and coffee are like the transition out from, I guess, stronger substances.
And it's true. And that's a treatment component, especially at these facilities that we watch that, we ask, we coach on that, right? If you, depending on the substances you're recovering from, man, some people sleep for 3 straight days if they haven't slept, and they've been up for 5 days straight, when they come in, it may be 2 days of straight sleep and they shouldn't have consequences at a treatment facility. It's monitoring. It's where we at in our withdrawal management is the correct
withdrawal
term.
Management. Okay. So that behavior would be condoned. Like if somebody needs to sleep for 3 days, they're going to be allowed to sleep for 3 days. Somebody's not going to shake them down after 8 hours of sleep and say, like, you need to get up, or do they?
Not typically.
Okay.
I can't say because anything could realistically happen.
Yeah.
But if there's a medical reason and you're open, I always say the best favor you can do yourself when you choose to go into a treatment facility is be open and honest to the best of your ability, because no one knows you better than you. And if you're not, you're just hindering getting your needs met. If you're exhausted and you're trying to drag through treatment and you're not doing anything, then it can be misconstrued as you're not interested or you're disengaged, and that can change. And if you just say, I am exhausted, I have not slept in days, I'm fighting to stay awake, then there's a different space there.
Yeah.
As opposed to not doing anything and sleeping, because that happens too.
Yeah. Okay. That's important to know. So then I guess, what is the basic framework for a day? What's sort of the flow that people can expect outside of like getting there and sleeping for 3 days just to like get your energy back a little bit? What is then sort of the expected framework look like?
So you should be seeing an individual therapist and having a thorough assessment done.
Okay.
You should be having a history and physical done, and you should be meeting with a medical provider, nurse practitioner, physician, pending they can do similar things that way. You should expect some version of labs to see where you're at. Individuals coming off of substances, or if they've been in a depression and haven't had a balanced meal, your electrolytes are off, right? We need to know, are you dehydrated? If there's people that haven't been drinking or eating because their depression's so deep, so that you should have some kind of lab work done.
Okay.
And you should have I say this because you should have a structured wake up time and an expectation. People never like this, but this is how you know it's a good place, right? Because you should have an expectation for your space to be clean. This is typically a shared space. You should be getting up and starting to learn a healthy daily routine again.
Okay.
And that time should be built in. Then you should have breakfast. You should have medication. Will
the food be healthy, or is it most of the time just like cafeteria food?
So it's cafeteria food typically, but it follows American Heart Association recommendations. So your calories will be aligned. Usually if you're hungry, you can have seconds. Sometimes you need a higher calorie diet if you haven't eaten and you're underweight. you may need something different. Typically, I tell people expect more bland food.
Okay.
Your gastrointestinal system is probably not doing so great, and
Yeah.
nausea affects people with anxiety and substance use and other disorders. I mean, that's a component, is the physical changes.
Totally.
So
Yeah. When I'm really anxious, or especially back when I was like struggling with severe anxiety, I had no appetite. It was I just had to cram food down just to stay alive. I mean, that was really the idea. So yeah. Okay. That makes sense.
yeah. And you should expect to be in treatment, group therapy. There is milieu management therapy. It's true. I mean, and there's a benefit to sit in a room full of people with shared experiences. There's good and bad. Trigger warnings, right? Other people can share things that can feel overwhelming, but you also can garner support and learn from people.
Right.
People are in different stages. There's people that are coming back into recovery after successfully completing it and having 2 or 3 year period where they were in recovery and had a setback of a relapse. You can still learn a great deal. What helped you when you were out? Like what happened that caused the relapse? Do you remember? And you learn a lot from people's shared experiences. So I'd expect to see that. And some, you should be doing work. I tell people, like, you should be doing work. You should be doing worksheets. You should be journaling. You should be meditating. All of that. It's college on a different level or something, right? Like,
Yeah.
you're doing work. If
Yeah.
you're not, then it's not probably at the best treatment facility.
Yeah, there's not a lot of just like sitting around, laying around. You're working on yourself while you're at the facility.
Yep. And then you should see some healthy recreation time, because you have to learn how to re-engage in activities that are fun again, right? Like shooting hoops, or basketball's on my brain. It's the Hoosier in me.
Yeah, I know, me too. That's the Hoosier in me. Love basketball. Love to shoot some hoops. Okay. Totally.
And yeah, so that should be in there. And if it's there's recovery groups, typically like 12-step, you should have some peer recovery coaches in there if that's the program you're in. You should have some downtime there. I'm like, you should be working now. You should have some relaxed time. It should be built in.
But it's deliberate. It's built into the overall program. In a sense, it's productive because it's filling a function.
Yep. And I will say this, because this is important, because people get real upset about this. When you're looking at the treatment facility, like, they should have a handbook that tells you what to expect. There should be consequences if you're not doing what's expected of you. I mean, you're learning to live again. They have an entire building of people, But the other thing is, most treatment facilities, can't say all, you will be detached from the outside world, at least initially in the beginning. And you shouldn't be accessing your social media accounts. I mean, yes, a loved one that's a healthy support, you should be able to talk to, but it's usually like a day or two before you even do that, to allow you to adjust and settle in. But you should see, like, no cell phones, people aren't around that, and limited access, because even if you think you're like 4 phone calls away, I say this about ex relationships, right? I tell people that I counsel this often, you're probably 4 phone calls away or 3 social media checks before you can connect and tap back into that person, right? You need to get some separation there if it's unhealthy, and you need some boundaries rebuilt. So that's just the truth. But it's an important truth. I know why people get mad. It's an addiction. The phone is an addiction, just like everything else. But if it's going to help you in your recovery, I think it's good to know that. Yep, 100% true. So that's another expectation. And I tell people, when you're doing that Google search and read the reviews, because they should be mixed.
Okay, they should be mixed.
Like, it shouldn't be like, this is the great. There should be some that are like, this is the greatest place on earth. I loved everything about it. Everyone's so kind, etc. There should be a couple that are like, I hate it. They're so mean. They make you do this, because you want to see that there's a balance. Everything's not rainbows and kittens. Like, you're doing work. You should be challenged. There's going to be things that you don't like, even in outpatient therapy. If your therapist doesn't make you mad or say something that kind of gets you like once or twice, then they're not pushing you to do things. And if you've been in therapy at all, there's at least that one session where they were
Oh,
so
yeah.
right. Why did they say that? I'm so mad, because you got to reflect on it and learn and
Yeah.
grow.
Yes, no, totally. I mean, there's definitely sessions for me where I left feeling frustrated, but that's honestly where a lot of the growth took place.
Absolutely. So that was the other thing I wanted to say, because there should be definitely mixed, like nothing, no one opinions, what we say about opinions, right? No one only loves this place. Like someone didn't like something. So that's a cautionary tale for me. If I go to look, even when I'm picking a therapist, if it's all like greatest thing ever, I love everything, I'm like, no, they're editing out some bad ones. Like I'm with you. I see what you're doing. Like,
yeah, no, that's really that's a good point to call out too, because I think people do look for, they want to find the facility with the best reviews, but that could be they're hiding something.
Right.
You want to find a place that has, and when you are reading the reviews, like it should be, like this therapist really pushed me, or like it should be something where it's like, okay, that makes sense why that irritated that person, but it doesn't detract from the fact that it's a quality facility.
Correct.
Yeah. So are there any reviews that if you see kind of reoccurring, you're like, okay, I should probably avoid this place?
If I see like environment of care, if I see like it's dirty, it's not clean, then that's one that I'm not interested in looking at. And that's a recurring thing, right? Like we've all been to a hotel, right? Where like you got one bad room, but for the most part, everything else was beautiful.
Yeah.
Then you wonder, but you think about it, right? If you see this constant like reoccurring thing on like not having good hygiene there or something, then that worries me.
Yep.
If I see things that are really just along the line of they're mean, they mistreat you, all they do is yell at you, then I'm curious, right? Like I'm like, ooh, you can be upset, like, oh, they're really strict and they make you do this stuff every day. Okay, I like you, right? I need some structure in my life, versus they treat you poorly, they yell at you, things like that. I'm like, okay, I'm not a big fan. And if I see that a lot, then that's probably not a facility that I want to choose.
Okay.
And this is another thing to think about, is I do look for accreditation, which is a whole nother big, long thing that I won't go into, except all it means for us as consumers, is that they have to meet a certain set of standards to maintain that, right? Like, that their environments has to be kept clean or they're in trouble. They have to follow treatment protocols that are up to date with SAMHSA's recommendations for evidence-based treatment, because they're held accountable for that. They pay money for that.
Yeah.
These centers will pay to have people come in and investigate their center so they can keep that gold star standard of Joint Commission.
So you want to look for an accredited facility then, it sounds like.
That's my choice, especially for inpatient. I want to look to see if they have a Joint Commission seal. If they have for substance use, it's called CARF. It's the Commission of Accreditation on Rehab Facilities, so CARF. And other ones have COA, which is the Council on Accreditation. So I try to look, and actually some of the you'll see it right on their website. If they are accredited, it'll be across the bottom, like, okay, Joint Commission Gold Seal. You're like, okay, that means every 2 years you meet all their standards and you're committed to that because you pay for them to come find things you're not doing perfectly.
Yeah, which is good. If they're actively seeking that out, that's a sign that they really care and want to provide the best level of care.
Mm-hmm. Awesome. It's a good sign. It's miserable when you're there. No, I'm just kidding.
When you're working at one of those, yeah, I could only imagine what that would be like.
It's not perfect, right? That anxiety again, but it's so worth it. If you want to be at the top of your game, you want to work on those things. So. Okay.
And then I think finally, when the person's getting ready to leave, what is like kind of the 1 to 2 piece of advice that you would provide to somebody when they're leaving a facility like that?
we touched on it, but I'll say it again because I'm going to circle one more time, is that what's your discharge plan?
Yep.
You should be leaving, if you're coming out of a highly structured program, with a plan for structure.
Okay.
You should have a support group identified that you can join online or in person. You should have appointments for follow-up with a psychiatrist if you're on medication, with a therapist for sure. And if you have some co-occurring medical conditions, with your primary care physician. So you should have things that you're expected to do when you leave. And you should say, that's a tough one. You have to remember that you're leaving and you're coming into an environment that has changed while you were away. And you got to be prepared for that, right? Your friend, especially if you're going to a substance use treatment facility, your friends should change. They shouldn't be waiting for you when you get home, right? Yeah. I mean, typically maybe one or two, but you should have a different set of friends that can live a recovery lifestyle with you, that understand what you're going through. And you have to understand too, you should do some family therapy while you are in these facilities.
Yeah,
for sure. Ask that question, but your family's going to be different, right? They're a little bit apprehensive, right? They want to make things better for you. They don't know how to act. They don't know how you're going to act. So you have to learn this again. It's all about grace and boundaries. It's you have to expect that almost, right? If they were watching you, I think of parents, if your mom was sleeping or not sleeping and checking on you every 15 minutes because she was worried because you were so depressed, that doesn't just stop. We did it when you were a baby, right? To make sure you're breathing. We're going to do it probably till you're 80 and we're gone. But I just say that it's just that this is an opportunity to learn to be a new person and to have some changes and your interests change. All of that happens. So, it's just boundaries and one day at a time, because it'll change every day and minute to minute sometimes. So give yourself grace.
Give yourself grace and be prepared for the change, because it's going to happen, but it's positive in the end. Mm-hmm. Awesome. Well, Lyndsey, I think you've done a really, really great job with this interview. Two things for you. Where can people get into contact with you if they want to learn more? I guess would be my first question.
So I don't know. I'm on LinkedIn as usual.
Okay. Perfect.
It's Lyndsey White. I will make sure you have that too if you'd like to share it. And then, I work right now in private practice and with the healthcare association. So I have contact that way as well. So email's always super easy. So I'll make sure you have that as well to disseminate.
Perfect. Awesome. And then what is one piece of advice that you have for somebody to get started on their mental health journey?
I tell people all the time, for you to even acknowledge and be comfortable that you want help, that is one of the probably bravest, hardest things that you can do. It takes so much courage just to say, I tried, I need something, like, please, I need help. And don't be afraid to ask. People always worry, that if you tell someone, I do a suicide training, and this is probably the most powerful thing I learned when I started it, was it's almost a relief to hear something's going on, because then it's out in the open and you can tackle this together. I have patients tell me, I didn't want to tell my mom I was having these thoughts because I didn't want to be a burden and I didn't want her to worry. And I remember doing a family session and the mom's like, I was so worried. I actually felt better that you just said it. Like I was losing my mind worrying. So it's just, the more you can ask and reach out, those are the things that save everyone's life, right? We say with suicide, it's a permanent solution to a temporary problem. And anyone that has lived through that experience can tell you the greatest thing they ever did was tell someone. So.
That is so powerful. So tell somebody, if you're struggling, it's rather than looking at it as being a burden, it's probably bringing relief to the people that love and care about you, to let them know. Well, Lyndsey, you've been an excellent guest, a wealth of knowledge. I think this is going to be helpful to get people started on their path, especially if they're exploring some sort of treatment facility. So thank you so much for coming on the You're Not Alone podcast and sharing that information with my audience.
Thank you so much. I'm much gratitude for being here and this platform to have this conversation with you and your listeners.
Absolutely. We'll have to bring you on again soon.
Anytime.
Okay.